So for today's session, I am delighted to be joined by Sarah Leyland from the Royal Osteoporosis Society. Sarah is a specialist osteoporosis nurse and clinical advisor to the ROS. So hi Sarah, thank you so much for joining.
Hi.
Are you keeping well?
Yeah, I'm fine, thank you, and it's great to be here.
Oh, good. Yeah, we're really pleased you can join us. My name is Zoe Clark. I'm Self-Management Programme Officer here at NASS. And today in this live session, I'm going to be chatting with Sarah about osteoporosis and the link with Axial SpA. So shortly, I'll be handing over to Sarah for a short presentation before we have a Q&A session. So please do pop any questions for Sarah in the comments and I'll make sure that we go through all of them. And as always, the video is going to stay on our page afterwards, so you can come back and catch up at any time, and we'll also pop it onto our website on My AS My Life. I've just seen a comment coming from Kathy. Hi, Kathy's based in Tunbridge Wells, so thanks for joining us. Yeah, and it'll be great to see your experiences. Pop any questions or comments in the comments box, and yeah, hopefully you enjoy the session. So I think we're ready to get started, Sarah, if you want to jump into the presentation, and then we'll come back for some questions afterwards.
Thanks, Zoe. Okay, right, so I'm going to share my screen with you, hopefully, and talk through osteoporosis, fragility fractures and bone health. Are you seeing that, Zoe?
I can't see that there. Ah, here we are.
Are you seeing that now?
Perfect.
Great. Okay, so just for about 10 minutes, I thought I'd give you a bit of an introduction, talk about osteoporosis, fragility fractures and bone health. And just going to begin really by telling you what osteoporosis is. So it's a medical condition when bones lose strength and they break more easily. And it's these broken bones or fractures, often called fragility fractures, that can cause pain and disability. And it's the spinal fractures that can result in height loss and spinal curvature, which we know is associated with osteoporosis. And osteoporosis is also a term used as diagnosis. So you are said to have osteoporosis if your bone density is lower than the average adult. Now, I've got a few pictures here which I thought might be useful. Talking a little bit about what happens inside the bones with osteoporosis, we need to think about the skeleton, our bones, as a living organ, really, constantly replenishing itself. So the bone gets worn away and rebuilt to keep the bones strong. And this all gets a bit out of balance with osteoporosis. So I've got three little pictures here to show what happens inside the bone. So the outer shell to the bone gets thinner, and all those struts inside the bone, they get thinner too. And eventually the whole structure, as you can see on the right, breaks down. And then what can happen is that bones break and we get these fractures. And I've got three pictures here of typical fractures with osteoporosis. So a broken wrist, compression fractures in the spine, and then the hip fracture on the right, which is the top of the thigh bone. So bones lose strength and are more likely to break. Out of balance is what you need to think about. Bones not rebuilding in the way they used to. And the important thing, of course, is that they have a huge impact on people's lives. So not for everyone, bones do heal, but for many people, a huge impact in terms of people actually not being able to live independently, often ending up in hospital for long periods of time, not going back to their own homes. And then, as you can see at the bottom, the changes in body shape with a spinal fracture, curvature of the spine, height loss, physical effects on people in terms of eating, breathing, pain problems, but also all sorts of psychological problems, loss of self-esteem, changes in the way people feel about their body. So a huge impact. And we know that osteoporotic fractures are very common. 1 in 2 women, 1 in 5 men breaking a bone after the age of 50. And why does it happen? Well, we know there are many different risk factors, and I've actually highlighted those that might be particularly relevant for those of you listening, particularly those with axial SpA. But generally, bones getting thinner and osteoporosis more common as we get older. There's a genetic component. We know that Afro-Caribbeans are less likely to have osteoporosis. We know women are more likely to get osteoporosis, particularly after the menopause, as they lose the protection given by the estrogen hormone. We also know that once you've had one fragility fracture, you're much more likely to have another. So that's an important risk factor. And we know there are other things too that you might be able to actually make a difference to. So very low body weight, being immobile, not as active as you were, particularly long periods of immobility. We know that smoking, we know that excessive amounts of alcohol, and people likely to fall over are more likely to break bones too. And then there are a whole risk of what we call other risk factors, and this is really medicines or medical conditions that affect bone. And I've highlighted again, particularly steroids, which might occasionally be used, certainly are used in inflammatory conditions generally, which affect bone. But we know other things too, like breast cancer and prostate cancer treatments can make bones weaker. And then we know that medical conditions across the board have something to do with osteoporosis, and top of the list, obviously with Axial SpA, is there's something going on with inflammation that seems to affect bones generally, and that's why people with inflammatory conditions do seem to be more at risk of osteoporosis. But there are many other conditions too that affect the way we use food, and that affect our hormone levels, and these too can put us at risk of osteoporosis. So how do we know if our bones have lost strength? Well, we don't have a perfect test, but we do have two approaches that are used to test, to check out our bones. The one is, many of you will have heard of, is bone density scanning, DEXA scanning, and the lower your bone density, the greater your risk of fracture. So if your osteoporosis will often be diagnosed by having a bone density scan, and if your bone density is much lower than the average adult. And then we have another approach called fracture risk assessment. So when you go to the doctor, not only will they look at your bone density, but they'll look at all the other risk factors that research has shown us are linked to low bone strength and fracture risk. And those are the ones I described. And what they'll do is they'll give you a percentage risk of breaking a bone in the next 10 years. And that's important because we do have effective drug treatments now to try and strengthen bone and reduce your chance of breaking a bone. And I've just listed them here. The commonest drug that's used for osteoporosis is something called a bisphosphonate. So you may have heard of alendronic acid or zoledronic acid, but there are other treatments: denosumab, teriparatide, strontium ranulate, occasionally HRT, and there's a new drug that's got a lot of interest in called romosozumab. And the drugs are given, as I say, to those who've got a high fracture risk. Usually that's when you're over 50, but sometimes the drugs are used for younger people with strong risk factors, such as I said, the high steroid use. They're already breaking bones easily, and they have that low bone density. So there are things you can do to help keep your bones strong. This is a quick list. I was just talking to Zoe because actually, there's another video actually on this Facebook which covers lifestyle approaches to bone health in quite a bit of detail, so you might like to look at that as well. But what is important is that you have a healthy, well-balanced diet, plenty of calcium and adequate amounts of protein, that you're doing what we call weight bearing with a bit of impact exercise and also muscle resistant exercise just to keep bones strong, that you try and have an appropriate body weight, so there's a good amount of weight pulling down on your skeleton. That helps to keep them strong, your bones strong. Not smoking, not having excessive alcohol, having adequate amounts of vitamin D from sensible sun exposure, or in some situations with supplements. And then also thinking about, as we get older, keeping our balance and our muscle strength good to prevent us falling over. So that's the sort of bone health story. So I hope that's given you a bit of an introduction to osteoporosis. And I just wanted to finally say that we at the charity at the Royal Osteoporosis Society have lots of information on all these topics, as well as, and I don't have time to go into it, how to live well if you have got painful and difficult fractures to cope with. And we have a free specialist nurse helpline. We have a support groups, which are still running digitally at the moment. And we have a membership you can join and get regular updates. So I hope that's given you a bit of introduction to osteoporosis, and as Zoe said, we're going to go on to talk a bit more now about the links between osteoporosis and Axial SpA and any other questions people might have, really. So over to you, Zoe.
That's wonderful, thank you. That was a really good introduction to the topic, and to give everyone some background information on what osteoporosis actually is as well. We've got a few comments coming in, and just to let everyone know that any resources we refer to during our chat, we'll make sure that we put them in the video description after the session, so do come back for those links afterwards. So really the first thing I'd like to ask is, for people with axial SpA, are they actually at more risk of having osteoporosis?
Yeah, I think that's a really good question, Zoe, because I think the answer is sort of yes and no, in the sense of, you know, there may be some people who are, particularly with very severe AS, who are perhaps even taking steroids like prednisolone. As I said, that can put you at greater risk, or that their mobility has been reduced or restricted if they're very much affected by the condition. And maybe that's less so these days because they've got other more effective treatments rather than steroids, but I understand that in some situations that could put you at risk. Also, as I said, there is something about an inflammatory condition. There's something going on there that seems to affect bones. So that could be why there is an increased risk. And of course, we mustn't forget that people can have both conditions. So as we get older, you know, you may have your axial SpA, but you could get osteoporosis too. So you may be sort of dealing with both and trying to understand what's going on with either. So that's the kind of yes bit. But I think no, in that I don't think axial SpA is top of the list. It's not one of the strongest risk factors. So you're unlikely to need specific investigations or scans or so on, unless some of those other risk factors are affecting you. So yes and no, but on its own, I don't think it would prompt a scan or a risk assessment.
Oh, that's really helpful, thank you. For individuals, how would they kind of understand their own risk of developing osteoporosis, or you know, how would they find out that they have it?
Well, I think thinking about the risk factors that I touched on, you know, is there something there that specifically relates to them? If they have broken, particularly if they've broken a bone more easily than you would expect. So a simple fall, perhaps, and breaking a wrist, or multiple fractures, things happening there that you wouldn't really be expecting, because we do know that having had one fragility fracture, you know, much more likely to have another. So it's an important risk factor to think about. So I think it's looking at those risk factors and thinking, does something there apply to me? And particularly in older age, because we know women are protected very much with their hormone levels until they reach the menopause. So we see these changes, we see these fractures and changes in body shape happening in later life, mainly with osteoporosis.
Okay, and then the scan that you mentioned earlier, the DEXA scan, if someone with AS has fusions in their spine, would they find that that would affect the results from the scan?
Well, it might. Certainly many things that happen to the spine can make it look denser on a scan. So if you've got a lot of arthritis, or you've got a previous fracture, we've had some kind of surgery that's involved in implant or a rod or something, well, we know that that can actually affect it. But a skilled radiographer should be able to take this into account and use perhaps other parts of the spine when they're doing an investigation, or they may be able to concentrate on the hip, because we scan the hip, so it may be that that's a more appropriate place. So it's certainly worth a discussion, but it shouldn't preclude you having a scan or a successful scan.
Oh, that's really helpful to know, because I know some people do find that difficult. So yeah, I guess we just reiterate to speak to the doctor who's referring you and to the radiographer,
yeah,
and work out a way to do it. And in terms of the osteoporotic fractures that you mentioned, are they more common for people with axial SpA, or is that quite separate?
I think that's another really good question, because as I say, we get these spinal fractures, and also if you've got, you know, a severe form of AS and you're going to get fusion, and you may indeed get some kind of fracture occurring in the spine. Whether it's actually an osteoporotic fracture, I think, is another question, because bone gets very brittle with severe types of AS, and it may be that it's not actually an osteoporotic fracture, but something slightly different. So I think it's really important to have that conversation. Again, I think if you've got a good clinician, that they're going to be able to discuss that, and if you're having x-rays and so on, they should be able to look at that with you. And I think actually I think what we do know is that the symptoms of fracture, of spinal fracture, are probably a bit different. So when one's being assessed, they're going to be looking at you as an individual and trying to work out what type of sort of pain you're getting, and whether it's a different sort of pain with what we do know, for instance, is that with a spinal fracture, it does seem that the pain is particularly worse when you're kind of leaning forward. So standing at the sink and doing sort of washing up, that kind of thing seems to be a particular problem. And we know that that's quite different if you've got a fracture or having a flare up with axial SpA, where, you know, we know there that the pain can actually get quite a lot better with a bit of movement and exercise. We know that it's something which doesn't stop you going to sleep, but might wake you sort of early in the morning. We know that the pain is kind of perhaps more in the buttock area. So when they're looking at these different types of fractures, they're just really having to look at you as an individual. And I think with osteoporosis, they'll be thinking, is there something here that sounds like this person is at risk of osteoporosis? Are they older? Is this someone who's low in body weight, who's got that pattern of pain, who's perhaps broken a bone already? So they sort of build up a picture really to try and understand, is this a spinal fracture we're looking at here?
Oh, that's really helpful, because certainly I know some people get really severe flare-ups in the spine, and it can be difficult, you know, to differentiate. So it's really helpful. And I guess, yeah, from what you describe, it's sort of comparing to their usual AS symptoms, axial SpA symptoms, and seeing if it's a different type of pain.
Yeah, and I think also we need to think about age, because I think usually people with axial SpA, it's something that's going to happen earlier in life. These fractures and osteoporosis is much more of an issue in later life. So I think that's another important point to make. And when people have a spinal fracture, they may get no symptoms at all, but if they have an acute pain problem that comes on, it lasts for sort of 4 to 8 weeks until the pain pattern, the pain improves, the healing takes place. And then one goes on to have that longer kind of mechanical pain type problem because of the changes in the body shape. So it's not quite the same pattern of pain. So I think understanding that can be useful.
Absolutely, yeah. And I know we've touched on a little bit about the importance of exercise and the different types of exercise as well. And I just wondered if you had any sort of resources that we can refer people to afterwards or anything.
Yes, we do. And I was talking to you before that we've done a really interesting project recently looking at exactly what type of exercise you need to do to help your bones, because obviously there's exercise to promote bone strength. That's one of the things we get asked about. This might be an area where I guess you're going to have to balance your individual needs again, because for bones you probably need to be doing something that's got some force and for the best, the optimum, some force and impact behind it. And I do understand that if you've got a flare up or you're prone to those kinds of problems, you're going to be a bit cautious perhaps about the higher impact type exercise. So again, I think that's something that you'll need to think about. But muscle strengthening, really important, and important for both conditions. And from a fracture point of view, you need muscle strength and good balance. And if you've had fractures in the spine, you need to think about posture and how to move and lift. And I think that's very similar, isn't it, for someone with axial SpA. So I can see lots of crossovers. So we've got information on exercise for promoting bone strength. We've got exercise to prevent falls, but we've also got looking at exercise to help protect your back. So how to move and lift and feel confident about all that despite having your osteoporosis diagnosis. And so, yeah, we've got videos and fact sheets on our website, and I think people might find that really useful from both points of view. Yeah.
Absolutely, that's music to my ears, because that's the thing that we're constantly sort of reminding people about and promoting it and teaching people about. So it's actually quite helpful that if someone has axial SpA and osteoporosis, you know, the advice and the approach is going to be pretty similar. So you know, we'll link to your website with all of those resources so people can have a good look around. And
yeah, absolutely. Yeah, and I think what we try and do, and I'm sure you do too, is think in a kind of positive approach to exercise, because when people have had a diagnosis of osteoporosis or they've had fractures already, then they're quite fearful. They really don't know where to start. So it can be useful to have a look at some of the reassuring information about what's safe and most things are safe, but also think about a referral to a physiotherapist if you've had an osteoporotic spinal fracture, to get a bit of guidance. And I know many people with axial SpA are getting that kind of advice, aren't they, all the way through. I guess fatigue might be the other thing, which is not such a common problem, particularly with a spinal fracture. So I guess it's going to be about pacing and looking to introduce things that are right for you. yeah, I'm weighing up those two conditions together.
Absolutely, and the more knowledge people can get about managing it safely, the better, really.
Yeah, yeah.
That's excellent. And I mean, the final question I have is a more specific question that we've had on the helpline a few times before about one of the medications you mentioned, the bisphosphonates, where they work to help with bone growth. If someone has axial SpA, do they then end up with the sort of converse reaction where they get fusions and too much bone growth with that medication?
No, I can understand that concern, but this is a drug that's working on the inside of the bone to try and, as I said, to sort of balance up the normal remodeling to make sure it's worn away and rebuilt in the right way. So that's all happening inside the bone. There's no change to the size and the shape of the bone, so no concerns there. So if people are being treated for one condition and they have axial SpA, that shouldn't be a problem at all.
Oh, that's really reassuring. Thank you. I mean, so we've gone through all the questions that I had prepared beforehand, and we've covered really a lot of ground in a short amount of time. So thank you so much for, the wealth of knowledge there. I'll check in on the questions. I can see out of the corner of my eye the questions popping up a lot. So we probably have quite a few to go through. So firstly, Donald asks about with Asian men, do you know the particular percentage of Asian men who develop osteoporosis?
I don't know the percentage. I know that generally people who are Asian, from an Asian background, are going to be similar to Caucasian in terms of risk. So they're not protected in any way. We do know, as I said, that Africa, Caribbean tend to, there's something about having bigger and stronger bones, which might be, but on the other hand, it doesn't completely protect you anyway, because you could be on steroid, or you could have age-related loss, which affects you in the end, or you could be on a medication of some sort. However, I think it's an interesting question, because we know that people from Asian descent actually may have a lighter, finer bone structure. They might have lower bone density. They don't always go on to have fractures in the same way. So I think it's an interesting one. And I think the important thing is to have that conversation. So if you're going to have your scan, talk to the scanning centre. They may have their own kind of reference ranges. They should be able to advise you about that. And also the fracture risk assessment tool that they use online, that there are different tools for different countries and so on. So I think definitely have that conversation, but there's no overall protection that you get in any way. And as I say, Asians are pretty similar to Caucasians in terms of risk.
Oh, that's interesting. Thank you. I suppose, as you say, it comes back to that kind of building that picture around the individual.
Exactly.
As well.
The overall risk, yes.
I'm not sure if you're able to answer this, or we'd refer Jane to the website, but Jane asks, how long should you take vitamin D supplements if you're not able to be in the sun a lot?
So the current recommendation, in fact, the government looked at all this just a few years ago, and certainly recommended that most of us should be getting enough through the summer months, certainly in terms of vitamin D from sensible sunlight exposure. However, if you are someone who really can't get, has reduced exposure to sun for whatever reason, and if you're in a housebound or so on, then you would be recommended to take a vitamin D supplement, and 10 micrograms or 400 international units is the recommended amount. And that you could take that, it's a very safe supplement, you could take that continuously, not a problem. As I say, the government decided that to top up the sunlight, we should all try and get a little bit of vitamin D through our mouths, either through food or supplemented drinks, or as a supplement. So getting about that much to top up your sunlight is not a bad idea, and indeed they say do seriously consider that during the winter months. And there's been a lot of advice through lockdown, which is that probably none of us are getting the sort of sunlight exposure we were, and if you do think you need to, because we really only get vitamin D from sunlight during the summer months anyway. So we're now back into, thankfully, sunlight again that's giving us vitamin D. So get out, don't get burnt, get to it, 10 minutes twice a day if you can. And if you think you need a supplement, you should be able to take that on a long-term basis quite safely.
Oh, that's wonderful. Yeah, I'm definitely looking forward to the summer months and hopefully getting out in some sunshine. And that actually leads on quite nicely to Kathy's question about sources of calcium, because she finds milk hard to drink.
Yeah.
Are there any top tips for her?
Yeah, well, certainly often we talk about dairy produce because it's got quite a lot in, you know, and it's also a big part of many Western diets, which I guess is why we talk about milk and cheese and so on. But you can get calcium in a whole range of other foods. So in pulses, in dried fruits like apricots and figs and dates, and also in dark green leaf vegetables. So, you know, your broccolis, your spring greens, also in things like tofu, which is synthesized with calcium. So you're going to get high amounts in that, or sesame seeds used in a paste form, something like tahini. So yeah, absolutely, it needs a little bit more thought, but you should be able to get it from non-dairy sources.
Oh, that's excellent. I imagine you've got lots of information on the website that I can link to in the comments section.
Yeah, indeed, we have actually, and also the Vegetarian and Vegan Society have a lot of information too, and you know, we work to sort of signpost to them.
Oh, excellent. I'll pop that in the links afterwards. We have a slightly more specific question from Debbie, so I don't know if it's something you'll be able to answer or refer to the helpline, but she's asking that her DEXA scan is very positive at 5.3, but she has lots of osteophytes in her spine, so they think it may be falsely high,
Right.
and she's got wedging of some of her thoracic vertebrae and has had previous fractures there. So she's just started alendronic acid and wondered what specific foods would encourage to help with bone loss, and also is it okay to do Zumba, which is quite high impact?
Lots of really important questions there. I'll try and cover a few things, but I think, as we were saying, you can always do call our helpline if you want to discuss any of those in more detail. So yeah, I think her main first question was about food and nutrition. Was that what the first question was?
Yes, alongside the alendronic acid.
Yeah, and I think as I quickly alluded to in the slides, it's that kind of broad-based diet. I know that sounds a bit obvious, but you know, they're well-balanced diet. It's not just about calcium, vitamin D. All the foods give us different nutrients. So we need protein, we need the different vitamins, we need the different minerals. So try and go with that eat well guide, you know, have the right proportion of foods, but within that try and get the, you know, make sure you're getting 700 milligrams of calcium a day. Very likely that if there's any doubt about that, they'll be giving her a calcium supplement alongside. That's really just to top things up. And similarly, many clinicians would prescribe vitamin D with the alendronic acid, again, just to make sure, and they might be giving you 800 international units, so a slightly higher amount. So that's quite likely. Good questions around exercise. There seems to be a suggestion if you're someone who's got spinal fractures, and it may be that wedging is indeed that there are spinal fractures there, then I think it's about approaching things a little bit more carefully. There's no absolute do's and don'ts, but we talk about building up and starting with the lower impact exercise. And if you've got an acute phase where, you know, the fractures are painful and in any way sort of disabling, then you need to wait for that period to have got, you know, to the healing to have taken place and the pain to have got better, and to just build up gradually. But certainly starting with the lower impact muscle resistance exercise. I think Zumba is fine as long as you're working within the comforts of your own, you know, limitations. So there's no absolute no's about twisting or turning or, you know, doing it smoothly and comfortably, building up. Perhaps if there's something that feels a bit too vigorous, then maybe miss that bit out and step back from. But if you've been used to something and the fractures have healed, then you can gradually build back up. And any questions, talk to the instructor and trainers that you're working with. And as I say, do call our helpline, because I think it's helpful sometimes to talk through your individual situation. So that kind of covered nutrition and exercise. And there was a good point actually about the osteophytes in the spine interfering with the reading, and we touched on that before. So that's where they need to be aware of what's going on for you. And as I say, they can use the hip, which might not be so much affected. And they need to look, as you said, that whole picture. What else is going on that tells us this person is at risk of fractures and who's likely to have weaker bones? Does that I'm not sure.
That was a comprehensive answer, thank you. And in fact, what you said about the exercise in terms of building things up gradually, that's exactly what we'd recommend for Axial SpA as well, to avoid a flare up when you're starting a new exercise. So again, sort of hand in hand, really.
Yeah.
Got another slightly clinical question from Steve, and Steve's just had a hip replacement. He's 42. He mentioned that the surgeon wanted him to stay on his crutches longer after the surgery because he said that the bone was soft when he did the replacement. He's wondering, does this indicate there may be something like osteoporosis going on?
It's an interesting one. The word soft it has a very specific meaning in the sort of clinical field, and soft bone often replies to something slightly different, osteomalacia, which is a very clear vitamin deficiency, mineralization problem, like rickets in children. I don't know what they quite meant by that. In fact, if there was any way of getting a bit of clarification of that, because it would be unusual for some. I don't think that's perhaps what was meant in this situation, whether there was there was it was a difficult, so what was the hip replacement done for? Was it done for an arthritis problem rather than a fracture? Sounds like it was.
I believe it was arthritis, yeah.
Yeah, I'm not sure what that means unless there was an area that just looked a little bit more vulnerable, and in terms of healing, they felt it was necessary not to overstress that area. It would be unusual at 42 to have an osteoporosis. It happens sometimes. I'd perhaps see a little bit more information, I think, in that situation so that I could understand it better.
That's really helpful. For Steve, I'll pop your helpline number in there.
Absolutely.
Yeah, also sounds worth chatting to the surgeon again as well.
Yeah.
And just checking, I think we've got one final question here. Let's see. So Judith's asking, so she says, I'm 65 and an ex-smoker. My pain has been centered entirely in the thoracic spine around the ribs and shoulders. It's much worse on movement and better with rest. So she said she's now concerned this may be osteoporosis as well as AS. And she asks, would they have spotted it on an MRI that she had a few years ago, or does she need a bone density test?
So MRI scanning can tell you something about fractures. It's not going to really be looking at bone density. When they're doing those kind of investigations, they would be looking at what changes are going on in the spine, and there might have been some information there. But I think if with any kind of back pain problem, it's getting that proper assessment, isn't it? So they can look at, is this the existing axial SpA problem, is there an AS problem here, is something else going on, giving them that full assessment. What are there any alerts here in terms of previous fractures, other medication use, is this someone who's older, who's slimmer, who's getting that overall picture, and then probably doing some kind of simple x-ray to just look at what the changes are, and then maybe moving on to look at bone density scanning as well to build up that picture. So really good questions, but back pain is so tricky, isn't it, trying to work out exactly what's going on, and it needs to be an individual approach, I think, an individual assessment.
Absolutely, and the difficulty is, of course, you can have more than one thing going on at the same time, which sort of muddies the water sometimes. So yeah, sounds like some individual assessments needed there.
Yeah.
Thank you. I mean, we've come to the end of the questions that have come in, so I'll give everyone a couple more minutes. If you have any other burning questions for Sarah, please do pop them in the comments there. I will also keep an eye on the comments over the next few days, so if we get any extra questions, we can answer them there. And Sarah, if you don't mind, I can pass them on to you.
Absolutely, yeah.
Thank you. So any final thoughts from yourself, Sarah?
Well, I was just thinking, I think you just summed it up there, where you said, these are two different conditions, both affecting bone. Understanding that's really important, but they can occur together. So I think it's about seeking out information, trying to get advice that really suits you, and then doing everything you can really to help you live well with both conditions. So it's been really interesting to think about them both together in the way we have. Yeah. I hope it's been
Absolutely, it's been really, really useful, and I think, as you mentioned earlier, kind of having the knowledge around the conditions really helps people sort of prevent it, manage it, and just giving people the confidence as well. So thank you so much. It's been really, really helpful.
Good, thank you. And as I say, we've got a lot of resources back at the charity, as you have, and the specialist nurse helpline, so people are very welcome to try and explore their own situation if they need to.
Wonderful, thank you. And we're getting lots of thank yous in the comments as well. One quick question before we finish. Debbie asks, does HRT give as good a protection as alendronic acid?
Well, that's another really interesting question. I mean, hormone replacement therapy used to be the kind of standard treatment for osteoporosis. It was the only one a few decades ago. And we've now got all these other treatments too. And we still know that it's effective. So I think, yes, if it's right for you, and that's usually someone who's either had an early menopause or they're in those kind of early postmenopausal years between 50 and 60. Once you get beyond that age, unfortunately, there are some kind of adverse effects that begin to kind of have to be considered, you know, such as breast cancer risks and so on, stroke risks, and they're less comfortable giving it for osteoporosis in later life. But yes, it works, and I think whilst you're taking it, if it's felt to be right, right for you, considering all benefits and risks, then it's going to be working for you. I mean, I think it's part of a journey, isn't it? And I think it may be that later on, and particularly as you reach 60 and so on, then they'll be thinking about a treatment that's perhaps more suitable at that time. But absolutely, it's an effective treatment for bone.
Okay, that's excellent. Debbie got there just in time. That's perfect.
All really good questions.
Absolutely, it's been really, really fascinating session. So thank you so much again, and I'll share with everyone watching that next week we have a live Pilates session with Wiebke Reichardt, so please do come along and join that session. Fits quite nicely in with our recommendation for exercise. And yeah, everyone can catch up on this video either afterwards on our Facebook page or on our webpage, My AS My Life. And we'll also pop all the links to the ROS website and all the resources we've mentioned as well. So thanks again, Sarah, so much. It's been really fascinating and loads of information. So yeah, hopefully have you again soon if you'd be happy to.
Thank you. I've really enjoyed it. Hope it's been useful.
That's wonderful. Thanks so much, and thank you everyone for watching and joining in and asking your questions as well. So take care everyone, and we'll see you next week.